Today, I will be demonstrating how to perform the Upper Limb Neurodynamic Test 2A. Just like the Upper Limb Neurodynamic Test 1, this test will bias the median nerve. And although the Upper Limb Neurodynamic Test 1 is used more often to assess the median nerve, 2A may be beneficial in patients who have had recent surgery within the shoulder region, or in those patients where shoulder abduction may be contraindicated, or their inability to do so due to a recent shoulder dislocation or instability. Neurodynamic tests challenge the physical capabilities of the nervous system by using multi-joint movements of the extremities to alter the length and dimensions of the nerve bed and their surrounding neural structures. These tests can be useful if the clinician suspects a neural injury by determining the presence of peripheral neuropathic pain in the upper extremity. The median nerve arises from the lateral and medial cords of the brachial plexus. It descends down the arm anteriorly to the elbow and forearm, then passing through the carpal tunnel of the wrist. This nerve provides cutaneous innervation to the hand and fingers via the palmar cutaneous branch and the palmar digital cutaneous branch. These branches give sensation to the palmar side of the first 3.5 digits. Minimal evidence exists for the efficacy of this test as compared to the Upper Limb Neurotension Test 1. Alpelby-Albrecht et al. Reported a sensitivity of 66% and a specificity of 75% in those with cervical radiculopathy. Overall, it has a fair rate of accuracy. Prior to beginning this test, you want to ask the patient about their symptoms. You'll start by having the patient lie supine on the table at a slight diagonal so the patient's head is closest to you. You as a clinician will stand facing the patient's feet. To start this test, you want to stagger your feet so your nearest leg is forward. This will help you apply the depression through the shoulder girdle and be able to support the shoulder as you're going through this test. So to begin, you're going to use your leg or your hip and apply shoulder girdle depression. This will take up the slack in the muscles and nerves, and it's very important that you maintain this position throughout the test. Your near hand is going to grasp the bottom of the elbow with your arm going over top of the patient's chest or abdomen. Just be sure not to actually rest and put any weight onto the patient. Your other hand, you're going to keep your finger spread and secure your thumb behind the patient's hand. Grasping at the elbow, you're going to apply external rotation of the shoulder, full supination, and elbow extension. From there, you're going to extend the wrist fingers, and if you need an additional sensitizing maneuver, you're going to add glenohumeral abduction to about 30 degrees. How's that? Okay. If they still don't complain of any symptoms, you can have them laterally flex their head to the other side. You okay there? Yeah. And if they don't have any symptoms at this point, that would be a negative test. Now have you bring your head back to neutral. If they have symptoms and bringing their head back to neutral relieves their symptoms, that would be indicative of a positive test. Now, if they do complain of pins and needles within the hand, you can reduce the scapular depression that you have on them. If that decreases those symptoms, that would also be indicative of a positive test. So there are 3 ways that this test can be positive. If this reproduces their initial complaints that they had, or if this starts new sensory symptoms within the extremity. And lastly, if you notice increased tissue resistance in the involved side as compared to the other side.